Okay, I'll try to speed up. Thank you very much for this nice introduction. And I just have to declare, I'm no consultant to Circle. All right. So together with Jörg Schwitter, my clinical colleague at the University Hospital in Lausanne, we were pondering, obviously, the question, how could we improve the throughput of the existing protocol at the time? And when we were thinking about this, of course, our eyes fell immediately onto cine imaging, because in cine imaging there is a lot of compressible time if you think about all these breath holds and in-between recovery periods of the patients. Now, luckily, when we were pondering that question, we had Michael Zenger visiting us from Siemens, who brought in his hand luggage a CV SPAR sequence, which is based on compressed sensing, and we plugged it into this protocol, and this led to this paper published by Gabriela Vincenti, which was also accompanied by an editorial of Dan Sodikson and Leon Axel. Now, what we did in that study, here on the left-hand side, you can see conventional multi-breath hold, short axis and long axis cines. And on the right-hand side, the same exact thing was done with compressed sensing in one single glorious breath hold. No dead time anymore, a much shorter acquisition duration, a couple of seconds. Then what we also did is we actually looked at the aortic flow simultaneously and the left ventricular stroke volume. We did that for both, on your left for compressed sensing, and on the right for the conventional method. And interestingly, what we found is the data correlate actually much closer using compressed sensing than with the conventional multi-breath hold approach, which advances the hypothesis that this discordance here may be associated with the level of the breath hold, which is not consistent in subsequent breath holds. So, of course, those who know me know that I've squandered my youth trying to develop 3D imaging of the heart, and so this was the next protocol we wanted to optimize. Why? Because if you look at conventional acquisitions with navigators, you have a lot of uncertainty, and also the ease of use is a problem, because everywhere I drew a little star, you need a user interaction. So you need a lot of user interaction. Finally, you have to position the navigator gating window. So a lot has to be done by the technician in order to get this right. And as you can see here on this little movie on your left, the navigator efficiency is oftentimes below 50%, which makes the scan, on one hand, unpredictably long, and on the other hand, very inefficient. The second hurdle, of course, as I just mentioned, is time inefficiency. If you look here at the heart throughout the cardiac cycle on the x-axis and throughout the respiratory cycle on the y-axis, what we basically do is we wait until these two time points roll around, end diastole and end expiration. And for the rest of the time, we just twiddle our thumbs. And I don't think this is acceptable. If you look at the efficiency of this, the duty cycle is less than 2%. And I think we ought to improve that situation. Now, we in our center, we developed a concept which we call total self-navigation, which is based on 3 pillars. One being a free-running sequence, which doesn't have any interrupt, no EKG triggering whatsoever. The second is physiological signal extraction from the center of K-space, and finally compressed sensing, stimulated by the 2D work I mentioned to you initially. So this is this golden angle 3D radial sequence. You just keep pulsing, irrespective of where you are in the EKG. This leads to a whopping 12 gigabytes of data and to images like this if you reconstruct them. Secondly, if you sit on the center of K-space, you can see, interestingly, it wobbles quite a bit. And if you look, excuse me, at the frequency distribution of this, you can come up with 2 filters, Fourier transform it back into the time domain, and you get a very nice respiratory and cardiac signal, which you now can use to bin the data I was just mentioning to you. And this is how it looks. We dilute now this data set into the respiratory direction on the one hand, and into the temporal cardiac direction on the other hand. And since this is golden angle, we can do that quite liberally because we always have a uniformly sampled subset in K-space. If you were to reconstruct these images individually, they would be rather noisy, but if you add compressed sensing on top of this, you actually get quite some good results. So now what's interesting about this, you can query the data however you wish. For instance, you could say, I want to look at respiration in mid-diastole, if this is something that might interest you, and then you extract such images. Or you can say, no, I want to see end expiration, but I want to see the cine to calculate, for instance, ejection fraction in these 3D images. Or you say, no, I want to see mid-diastole end expiration, and I move through the slices. So that leads to the lower panel here. And these images are hot off the press. They were just reconstructed 2 days ago. Okay, and we also did this already in patients. This slide was given to me by Giulia Cinami. You can see here an acquisition in a patient. If you reformat the right coronary artery, then you see this signal void here at this level, and then if you go into the cath, you can see, in fact, there was actually a stent that was placed there at this level. So if you remember the first slide with all these stars, you have only one star, you only need to position the imaged volume, that's it. You don't need to position an EKG, no nothing, and you have to worry about data extraction after the fact. And it's also more time efficient because you keep sampling all the time. Now, this will certainly lead to a paradigm that kind of looks like this. We now are thinking about adding contrast as a 6th dimension to this, and so we will end up having a sequence which is just push button, just similar to echo. But at the end of my talk, I also would like to show you some eye candy, and that is fetal imaging, because compressed sensing really made that possible. So we're also using golden angle, and this is just a regular gridding reconstruction here, and you probably agree that this image is quite bad, but trust me, at the level of the yellow arrow, there is actually a fetal heart. If we now reconstruct this with compressed sensing in real time, now I cannot see the slide anymore because a picture of mine is taken, but I imagine you can see now the moving heart with real-time compressed sensing reconstruction. If you now draw a little circle around this heart and extract the individual pixel intensities, you can also extract something which is like the EKG, rebin the data, combine the multiple cardiac cycles of this fetus, and reconstruct these nice-looking images. And just to give you an idea, we have now implemented a technique where you can interactively approach the anatomy of the fetus, of the heart, because the fetus is always moving, the mother is breathing, so we just approach the level of the heart which we want, and we just let go, don't touch it anymore, and the last 2 or 3 seconds are then used to reconstruct these images, a long axis, a 4-chamber view, and a short axis. And remember, this has the size of a hazelnut, such a heart of a little fetus. With that, I would like to thank you for your attention, and here you can read the conclusions yourself. In the interest of time, I stop here.